Welcome to the deep dive. Now, this deep dive is put together specifically for you, especially if you're an orthopedic resident gearing up for those big postgraduate exams, like the FRCS or similar fellowship exams. Our mission today is pretty clear. We're taking this collection of notes and research excerpts you've provided, and we're going to unpack them, pull out the really crucial stuff on clavicle fractures and ACJ dislocations. And just so you know, this material is based on the Ortho Made Simple notes, which you can find over at mokyingren.sg. They were put together by Dr. Mok Ying Ren. He's a sports surgeon at the National University Hospital in Singapore, and he went through this himself, completing his FRCS back in 2022. Okay, there's quite a bit to get through, so let's just jump straight in. First up, that bone everyone seems to break, the clavicle. What's the general overview here?
Okay, yeah, let's get into it. Clavicle fractures, super common, and mostly, like 80% of the time, we're dealing with mid-shaft fractures. When you've got one that's displaced, particularly in the middle, you really got to understand the forces involved. You've got the arm's weight just pulling that outer distal piece down. And then fighting against that, you've got the sternocleidomastoid muscle and the trapezius too, basically yanking the inner proximal bit upwards. Those are the main things causing the displacement.
Right, the classic picture. And what holds it together normally?
Yeah, the coracoaclavicular ligaments.
Yeah.
The CCs, you've got two main parts. The conoid, that's a bit more central, maybe 4.5 centimeters from the AC joint, and it's key for vertical stability. Then there's the trapezoid, slightly more out towards the shoulder, about 3 centimeters from the AC joint, more for horizontal stability. Their integrity is, well, it's critical, as we'll definitely see later.
Okay. And when is surgery just unavoidable? What are the absolute must-operate situations?
Yeah, the notes are pretty clear on this. The non-negotiables, basically. If it's an open fracture, obviously, any kind of neurovascular injury associated with it, or if the skin is really tented up, like it's about to break through, that's an emergency too. If you see any of those, it's straight to the OR. No real debate there.
Right, those make sense. But then we get to the gray area, the one that comes up all the time, right? That displaced mid-shaft fracture without those red flags. It feels like there's still a lot of debate about the best way to treat those.
Oh, absolutely. And the research you've provided really highlights that uncertainty. We're looking at some important randomized trials here. There's COTS from 2007, the clavicle trial published in 2017, and also an RCT by Elicha Bon in JBJS. Now, when you look at what they found about the bone actually healing the non-union rates, it's pretty consistent. Surgery does a much better job preventing non-union. We're talking maybe 1% non-union after surgery.
Compared to non-op.
Compared to something like 10, even 15% if you treat it conservatively without surgery. So on the surface, you think, okay, surgery wins.
Yeah, seems clear-cut. But then there's the other side of the coin, the patient's actual function.
Exactly. And this is the paradox, the really crucial bit for you to get your head around, especially for exams and, talking to actual patients. These same big trials, the clavicle trial looked at 9 months, the Elicha Bon study, at 1 year, they found no significant difference in the long-term functional outcomes. Things like the DASH-H score, which measures shoulder function, were basically the same between the surgical and non-surgical groups.
Okay, hold on. So surgery makes the bone heal much more reliably, gets rid of that 10-15% non-union risk, but at a year out, the patient's shoulder might work just as well, statistically speaking, even if they didn't have the operation.
That's what the evidence from these major trials suggests, yes.
Wow. Okay, so how on earth do you explain that to a patient sitting in front of you? That's a tough conversation.
It really is. And it's a classic exam scenario, right? You have to lay out this apparent contradiction. You explain, look, surgery significantly lowers the chance your bone won't heal properly. That's a clear benefit. But then you have to follow up with, however, these big studies show that your overall shoulder function down the line, say in a year, might end up being quite similar whether you have the surgery or not. Then you talk risks. Surgery means anesthesia risks, infection, maybe hardware problems, definitely a scar. Non-operative avoids those surgical risks, but carries that higher chance of non-union, maybe ending up with a noticeable bump or deformity. It really comes down to helping them weigh it up. What matters more to them? Avoiding non-union, avoiding surgery. It's about informed consent, using the best data we have.
That makes a lot of sense, framing it as their choice based on the evidence. Okay, so let's say surgery is the way forward. The notes talk about an anterior approach. Can you walk us through the key steps there?
Sure. So for plating the clavicle from the front, the anterior approach, you'll typically have the patient lying flat, supine, maybe with a small sandbag or bump between the shoulder blades, just to open things up a bit. The incision runs along the clavicle. You go through skin, subcutaneous tissue, platysma muscle, and then you hit a really critical point.
Nerves.
Exactly. Those supraclavicular nerve branches. You have to be meticulous about finding and protecting them. Damaging them can lead to some really unpleasant numbness or even painful neuromas over the front of the chest. That's a big deal for patient satisfaction.
Definitely something to watch out for. Once you're down on the bone, there's this debate. Plate on top or plate on the front? Superior versus anterior plating. What's the thinking there?
Yeah, it's an ongoing discussion.
Okay.
Traditionally, people liked superior plating, putting the plate on top, because theoretically, that's the tension side of the bone when the arm hangs down. But biomechanically, there's no definitive study saying one is absolutely superior in all situations. The notes mention a study by Uzer in JSES from 2017.
What did that show?
Well, it was interesting. It found anterior plates might be a bit stiffer against bending forces, while plates on top, or these slightly angled SAC plates, superior anterior clavicle plates were maybe better at resisting twisting forces. So it's not clear-cut. Clinically, though, putting a plate right on top often leads to more issues with prominence. Patients feel it under the skin, it can be uncomfortable with straps, things like that, and there's potentially a slightly higher risk to the subclavian vessels underneath if screws go too deep.
So the anterior or SAC approach might be better for comfort.
Often, yes. Anterior plating, or SAC plating like the notes seem to prefer, usually means the plate is less noticeable. Plus, you might be able to get longer screws in from front to back, potentially giving better fixation in some bone types. The preference in the notes for SAC likely comes down to that lower neurovascular risk profile and better patient comfort.
Okay. And just quickly, what if things don't heal? If you end up with a non-union?
Right, clavicle non-union. First step, always rule out infection. You need your blood tests, maybe imaging, potentially a biopsy. That's sort of triple assessment idea. Then you figure out if it's hypertrophic, meaning the bone tried to heal, lots of callus, but just didn't bridge, or atrophic, where there's very little healing reaction. But for a non-union that's actually bothering the patient, the basic principle is surgery. Take down the non-union site, get fresh bleeding bone ends, fix it securely, usually with a plate, and almost always add bone graft to kickstart the healing process.
Got it. Okay. Let's pivot now to the shoulder joint itself, specifically the AC joint, the acromioclavicular joint. How do we classify injuries here?
Right, ACJ dislocations.
Yeah.
The go-to classification is the Rockwood classification. It's all about how much the end of the clavicle has moved compared to the acromion, mainly looking upwards. And a key part of it is comparing the space between the clavicle and the coracoid process, that CC distance, to the normal uninjured side.
Can you run through the types quickly?
Sure. Type 1 is basically just a sprain of the AC joint capsule. No real movement, ligaments stretched but intact. Type 2, you get a bit of upward movement, less than 25% displacement compared to the other side. Here, the AC ligaments are torn, but the main CC ligaments are just strained. Type 3 is what most people picture as a shoulder separation. The clavicle pops up noticeably, between 25 and 100% higher than the other side. This means both the AC and the CC ligaments are completely torn.
Okay, that's the common one. What about the higher grades?
Right. Type 4 is different. The clavicle displaces backwards, posteriorly, often getting stuck in the trapezius muscle. You need a special view to see this properly. Type 5 is a really severe upward displacement, more than 100%, like double the normal CC distance. This means everything's gone, AC, CCs, and even the tough fascia covering the deltoid and trapezius muscles is ripped. Major injury. And type 6 is rare, thankfully, where the clavicle gets pushed down inferiorly, usually under the coracoid.
You mentioned needing a special view for type 4.
Yes, absolutely crucial. You won't reliably diagnose a type 4 posterior dislocation on standard front on x-rays. You need an axillary view shooting the x-ray beam up through the armpit to see that backward translation.
And any other specific x-rays we need for ACJ injuries?
Yeah. Besides getting standard AP views of both shoulders on one film so you can directly compare that CC distance side to side, the Zanka view is very helpful. That's an AP view, but tilted slightly downwards, about 10 degrees. It aims right at the AC joint and helps lift the clavicle image off the scapula, giving you a clearer look at the joint itself and the space for the CC ligaments.
Okay. And surgery for ACJs, when is it definitely needed, like the absolute indications?
Similar logic to the clavicle, really, based on instability and potential complications. The unstable types, Rockwood 4 posterior and Rockwood 6 inferior, generally need surgical reduction and stabilization.
Yeah.
And again, if it's an open injury or if there's any compromise to nerves or blood vessels, that's an immediate surgical indication too.
Right. So for the ones needing surgery, especially the acute ones, say, within the first few, maybe up to 6 weeks, what are the surgical goals and common techniques?
So for acute ACJ dislocations needing surgery, maybe a type 3 in a very active person, or definitely the 4s and 6s, the main idea is simple. Put the joint back where it belongs, reduce it anatomically, and hold it there. The thinking is that if you hold it reduced, the torn ligaments, especially those important CC ligaments, have a chance to scar up and heal in the right position. Now, how you hold it, well, there are loads and techniques, but the notes highlight a common comparison, using a hook plate versus using some kind of suspensory fixation device.
Okay, pros and cons. Hook plate first.
The hook plate is strong. It physically hooks under the acromion and levers the clavicle down, gives a really solid initial reduction. The big downsides, though, are that hook can rub under the acromion, causing pain, erosion, sometimes even a fracture of the acromion itself. And you pretty much always have to take the plate out later in a second operation.
And the suspensory devices.
Suspensory fixation uses strong sutures or synthetic ligament tapes passed around the base of the coracoid process and then up through tunnels in the clavicle, essentially pulling the clavicle down towards the coracoid, mimicking the CC ligaments. The pros. Often less hardware prominence can sometimes be done arthroscopically or minimally invasively and usually doesn't require removal. The main risk specific to these is potentially fracturing the coracoid when passing the sutures or tapes, or the fixation failing over time.
Okay, different techniques, different potential problems. What about the outcomes? Does one work better overall?
Well, this is where it gets interesting again, echoing our clavicle chat. The notes mention a meta-analysis by Arachikaran from 2016 that looked at exactly this, comparing different acute fixation methods. And guess what? They found no significant difference in the overall functional outcomes or the overall rate of complications between the different techniques, like hook plates versus suspensory fixation.
So similar overall results, but just different ways of getting into trouble.
Pretty much sums it up. Hook plates might give you acromial problems and need removal. Suspensory devices might have issues with coracoid fracture or fixation pullout. But the patient's final function seems to end up in a similar place on average. Another complex choice.
Okay, let's pause here for a quick reminder. You're listening to The Deep Dive, and this discussion is based on the Ortho Made Simple notes available at mokyingren.sg. Now, what if you see someone late? The injury happened months ago, it's a chronic dislocation, past that 6-week mark. How does the management change then?
Right. Good question. If it's chronic, say more than 6 weeks, maybe months down the line, those torn ligaments aren't going to heal just by putting the bones back together. They've likely retracted, scarred up, maybe disappeared. So simple fixation won't work anymore. You need to actually reconstruct the ligaments that provide stability.
And how do we do that?
The notes mention a couple of main strategies. One is a non-anatomic reconstruction, like the modified Weaver-Dunn procedure. That involves taking a nearby ligament, the coracoacromial, or CA ligament, detaching it from the acromion, and transferring its end to the cut end of the distal clavicle to try and provide some hold-down force.
Not recreating the original anatomy, though.
No, it's more like borrowing a structure to do a different job. Then there's anatomic reconstruction. This aims to actually rebuild both the AC and the CC ligaments, usually using tendon grafts, often allografts, from a donor passed through bone tunnels to mimic the original ligament pads. These bigger anatomic reconstructions often need some kind of protection while the grafts heal and incorporate, maybe with temporary fixation like a hook plate or even a suspensory device used adjunctively.
Okay, that makes sense. Now let's try and tie some of this together. Can we circle back to distal clavicle fractures? They seem to sit somewhere between midshaft fractures and ACJ injuries, especially concerning those CC ligaments.
Absolutely. Distal clavicle fractures, breaks in the outer end of the collarbone, near the AC joint, are classified using the Neer classification, types 1 through 5. And yes, it's all about where the fracture line is relative to those crucial CC ligaments.
And which types are the problematic ones, the unstable ones?
The key ones to understand, especially for exams, are Neer types 2 and 5. What makes them unstable is that the fracture line occurs medial to or before the point where the CC ligaments attach onto the clavicle. So think about it. The main shaft of the clavicle is still anchored by the CC ligaments, but the small outer fragment, which includes the AC joint connection, is now detached from those ligaments.
Ah, so the arm weight just pulls that outer piece down.
Exactly. There's nothing holding it up against the pull of the arm weight because its connection to the stable CC ligaments is broken off with the main part of the clavicle. Type 2 is just this unstable fracture pattern. Type 5 is similar, but also includes comminution, meaning the end is broken into multiple pieces. But the instability mechanism is the same fracture medial to intact CCs.
Okay. And what do we know about these healing? Is non-union common?
It can be. The notes mention a well-known study by Robinson and JVJS from 2004. It was a large cohort study looking at distal clavicle fractures. They found that being older and having more displacement of the fracture were definite risk factors for the bone not healing for non-union. But, and this is really important, they also noted that quite a few patients in their study who did develop a non-union actually weren't having many symptoms from it and didn't end up needing any further surgery.
So non-union doesn't always equal a bad outcome for the patient.
Not necessarily, especially in the distal clavicle, it seems. In terms of treatment, the options are non-operative, or surgery using things like special distal clavicle plates that hook around the end, maybe a hook plate like for ACJ injuries, or even those suspensory devices.
And I sense another lack of consensus situation coming, similar to the mid-shaft fractures.
You're spot on. It's the same pattern again, and the notes emphasize this. We know displacement is a risk for non-union from studies like Robinson's. But then, more recently, there was the COTS randomized trial, led by Jeremy Hall, published in 2021. This trial directly compared non-operative treatment versus surgery for these unstable, displaced distal clavicle fractures near type 2.
And the results? Let me guess. Surgery led to less non-union.
Precisely. A big difference, actually. Non-union rate was only 5% of the group that had surgery, compared to a whopping 36% in the non-operative group. Huge difference in healing rates.
To the function.
But you guessed it. At 1 year, this trial found no significant difference in functional outcome scores between the operative and non-operative groups.
It's almost hard to believe that pattern keeps recurring. Less non-union, but function ends up similar.
It is counterintuitive, isn't it? And that Hall trial also gave us some really important data on the downsides. They found that about 20%, so 1 in 5, of the patients treated without surgery eventually needed an operation later on, usually because the non-union became painful or the deformity was problematic. But on the other hand, an incredibly high number, 44%, almost half of the patients who had surgery initially, needed a second operation later, mostly just to remove the metalwork because it was prominent or bothering them.
Wow, 44% needing a second surgery. That's huge.
It really is. So when you're counseling a patient with a displaced distal clavicle fracture, it's another really complex discussion based on this evidence. Non-op, high chance of non-union, but function might be okay, although a 1 in 5 chance you might need surgery later anyway. Op's very likely to heal, but function might not be any better at a year, and there's usually a 50-50 chance you'll need another operation just to take the plate out.
That is definitely not a simple decision. Okay, let's try and synthesize all this. For you, the resident listening and prepping for exams, what are the absolute key takeaways from diving into these notes and this evidence?
I think the biggest theme, the thing that jumps out across displaced midshaft clavicles, acute ACJ separations, and displaced distal clavicles is this recurring finding from high-level evidence from these RCTs. Getting perfect radiographic healing, avoiding non-union with surgery, does not automatically mean the patient has better shoulder function in the longer term compared to non-operative care.
That functional outcome piece seems key.
It's critical. So for your exams, yes, you absolutely need to know the classifications near Rockwood. You need to understand the biomechanics, why things displace, the role of the CC ligaments, why certain fracture types or ACJ types are inherently unstable. You need to know the surgical techniques and their specific risks, nerve injury and clavicle plating, acromial issues with hook plates, coracoid fracture with suspensory devices. But arguably just as important is being able to discuss the actual evidence, referencing studies like COTS, the Clavicle trial, the BAN-RCT, the Hall trial, that Arakaran meta-analysis, and highlighting this disconnect that function doesn't always follow the X-ray.
Right. It's about showing you understand the nuances. You know why a near type 2 distal clavicle is unstable. It's medial to the CCs. But you also know the evidence suggesting that despite a high non-union rate with non-op treatment, the functional outcome might be similar to surgery, which itself has a high rate of needing hardware removal. It's that critical appraisal.
Yes. Exactly. It forces you to think beyond just making the bone heal. Is the goal bony union at all costs? Or is it optimizing patient function while minimizing complications and the burden of treatment, like second surgeries? The evidence suggests these aren't always aligned. So maybe a final thought to chew on as you study this further. Given that the primary goal is usually restoring function and minimizing harm, how should this evidence showing similar function despite different union rates and complication profiles actually shape your treatment recommendations in practice? Does it make you lean more towards non-operative management initially for some of these injuries, accepting the non-union risk? Or does the predictability of union with surgery still win out for you? It really challenges some traditional thinking.
A really important point to consider: how do we truly define success for the patient? Well, that brings us to the end of this deep dive, which, as a final reminder, was based on the Ortho Made Simple notes from mokyingren.sg. We really hope going through this has helped clarify some complex areas around clavicle and ACJ injuries for you. Thanks for joining us. Keep digging into the evidence, keep questioning, and best of luck with your exams.